I'm Milton Packer from the Baylor University Medical Center of Dallas, Imperial College in London, and I'm here to talk to you about the adipokine hypothesis of heart failure with a preserved ejection fraction. This is a new framework, just was published in JACC about 2-3 weeks ago, and it is such a important way of thinking about this disease. Now, we have for decades have had a unifying hypothesis for heart failure with a reduced ejection fraction. It was the neurohormonal hypothesis. But we have not had a unifying hypothesis for heart failure with a preserved ejection fraction. And many people have come up with various ways of looking at the disease. They have not really been well validated in clinical trials or even experimental studies. But one thing that everyone has noticed is that one of the most important features of a patient with heart failure and preserved ejection fraction is excess visceral adipose tissue, what I refer to as visceral adiposity. Now, it's not obesity. Obesity is measured by body mass index. Visceral adiposity is typically in the clinic measured by waist circumference or waist to height ratio. And almost everyone with HFpEF, heart failure with preserved ejection fraction, has excess visceral adiposity, increased weight to height ratio, and it's prognostic, powerfully prognostic. The question that has been so important is why? Why does visceral adiposity cause heart failure? And the reason is because when visceral adipose tissue becomes expanded, it changes its secretion of messenger molecules. They're called adipokines. And these messenger molecules move through the bloodstream and impact the heart. Now, in healthy people, adipose tissue secretes cytoprotective, cardioprotective adipokines, and they keep the heart healthy. But as people gain weight and visceral adipose mass expands, visceral adipocytes begin to make pro-inflammatory adipokines. They cause hypertrophy, fibrosis, and they cause HFpEF. And when we can measure these adipokines in the bloodstream, they're elevated in people who have obesity, elevated in people with visceral adiposity, elevated in people with HFpEF, and as you might imagine, they are correlated with the hemodynamic clinical severity of disease and prognosis. What's really impressive is that a lot of the drugs that we currently use for HFpEF, GLP-1 receptor agonists, SGLT2 inhibitors, mineralocorticoid receptor antagonists, they actually act on visceral adipose tissue to shrink it, changing its adipokine secretion profile to one that's healthy, one that's cardioprotective, reducing the adipokines that are pro-inflammatory and pro-hypertrophic. But what really makes this adipokine hypothesis work and what establishes causality are wonderful experimental data that show that if you take mice, feed them a high-fat diet, they will express these pro-inflammatory adipokines only in adipose tissue, and they will develop HFpEF. And then, if you silence these specific adipokines only in adipose tissue, without changing their expression in the heart, kidney, brain, or any other organ, then HFpEF doesn't develop. That shows that the source of the molecule that's causing HFpEF comes from adipose tissue. It's increased in adipose tissue when HFpEF occurs, and when it's silenced only in adipose tissue, then the state of HFpEF is ameliorated. So this is a really exciting hypothesis. We're doing an enormous amount of work now with new experimental data, new epidemiological analyses, and new clinical trials in order to develop new therapies targeting adipokines for the treatment of patients with HFpEF.